started. This is a continuation from the prior lecture. So, let's see how I'm doing. But we learned a lot about keratinizing squamous cell carcinoma last time. This on the upper left-hand corner is keratinizing squamous cell carcinoma. What we really mean is that the cytoplasm of the cells is very eosinophilic. It resembles stratified squamous epithelium in some way. Sometimes we can see that there is a cohesion between the cells and almost like a reduplication of like the desmosomes that are holding the cells together. And we either call it keratinizing or we call it conventional. But there are different subtypes of squamous cell carcinoma that can occur in the oral cavity or the larynx or the pharynx. We're not really like limiting ourselves too much to a part of the head and neck that have a different morphologic appearance. And some of them are considered a little bit more aggressive. And some of them are considered a little bit less aggressive than conventional squamous cell carcinoma. So as a general overview, these are the subtype that I think about in the oral cavity and the larynx. I would say that the ones that are considered somewhat less aggressive are verrucous squamous cell carcinoma and carcinoma caniculatum. Maybe papillary as well. In the kind of middle category, probably basaloid and spindle and epithelial, and then more aggressive the adenosquamous and the apoptolytic. And then we're going to go over all of them. And then just for reference, in the upper right corner is non-keratinizing squamous cell carcinoma. And so non-keratinizing, you can still see like a little bit maybe like keratin formation, but most of the cells will not contain like that eosinophilic cytoplasm, and it resembles more so the tonsillar crypt epithelium and not stratified squamous epithelium. And we'll go over this as well. So papillary squamous cell carcinoma, usually I think about it either in the larynx, as it has the space to kind of grow into that opening there as an exophytic mass, or we think about it in the pharynx. But the one that I'm speaking about first is the one in the larynx. And so there can be a keratinizing type that is related to smoking and drinking. It's kind of a theme. And then you can have the non-keratinizing type, which is most likely related to HPV. But we don't really test in the larynx very much for HPV. It doesn't really affect prognosis. Most of our HPV studies and HPV thought about the de-escalation and different options are for the oropharyngeal factories. So what's keratinizing papillary SCC? It's a complex papillary proliferation in excess of what you would think probably is squamous papilloma, with full thickness keratinizing dysplasia. So the cells are going to be pink, it's going to be probably dyskeratotic, it's going to be full thickness and complex bulky growth. When you're looking at this, do you see stroma? Not really. It's very hard to call this invasive. And we'll talk about that. Then there's the non-keratinizing variant. Again, very complex. This would worry you in excess of what a normal papilloma would look like. Plus, it's very little. So there's this non-keratinizing loss of maturation. The cells, the cytoplasm is not keratinizing. It's more like almost urothelial appearing, and it looks like it's going to be HPV positive, non-keratinizing squamous cell carcinoma. So for this one, your differential diagnosis is possibly a papilloma with dysplasia. Let's say you get a very superficial biopsy and you don't see invasion, and you're in the larynx, and in the larynx you have papillomas, recurrent respiratory papillomatosis, different processes like that. And you're kind of afraid to commit without invasion. The radiology is saying this is a huge mass, Like this is probably an excess of papilloma, but I don't have that invasion that would really reassure me to call this invasive squamous cell carcinoma. So what can you do in that situation? In that situation, you can write this note. Carcinoma, at least in situ with papillary features, and say that, because it's superficial, I cannot evaluate for invasion, but it may represent either carcinoma in situ arising in a squamous papilloma or a keratinizing papillary squamous cell carcinoma. Let them kind of make that clinical correlation in some way. For the non-keratinizing type, I would say just call it. The non-keratinizing, very streamy, blue appearing big tumor, you don't have to have evidence of invasion to call it carcinoma. Call it non-keratinizing papillary squamous cell carcinoma. If you don't want to put the word invasive in front, don't. Non-keratinizing papillary squamous cell carcinoma. This happens this is a tough call. This is a tough call on frozen. This is a tough call on a permanent section, but we've kind of accepted that they're so exophytic, they're so bulky, that how can the surgeon really almost get under there and get to the bottom of it and get to the stroma to give you that invasive component. But yeah, that's kind of, so we decide that these are probably an easier histologic diagnoses, and the keratinizing ones are the harder histologic diagnosis that requires a note. These behave similar or maybe slightly better than conventional SCCs, probably because the depth of invasion is probably not significant. What about spindle cell squamous cell carcinoma? So these have a very strong male to female ratio, 12:1. And again, this is most often an exophytic mass in the larynx, an ulcerated exophytic mass in the larynx. Maybe not so papillary, but at least bulky, polypoid, something like that. They're thinking polyp, they're thinking granulation tissue, some sort of a mass that has space to grow into that opening in the larynx. And oftentimes it's going to be very, very ulcerated on the surface. So how does it look like? I'll go back to this. So for example, here are some tracheal rings, and we have this kind of polypoid-like mass. A little bit of epithelium, squamous epithelium overlying the surface, underneath pretty busy proliferation of cells. And even from this tower, you can tell that this is polypid, they're very dark, hyperchromatic, there's mitotic activity. But this is not always the case. And sometimes this can be kind of bland and kind of hard to find. You really have to search. So you have to be in your polyps that you are biopsying from the vocal cords, in any kind of masses that have somewhat a spindle-like appearance, stroma. Really look closely. Don't just quickly just go, okay, next one, polyp, next one. Think about this. What can help you make the diagnosis? Well, yes, the presence of atypical mitotic figures, hyperchromasia, things like that. Another thing that can help you is if you have at least a little bit of a squamous dysplasia or carcinoma in situ in the overlying epithelium, or if you have some squamous component that mixed with your spindle cells. Now look at these spindle cells. They don't look so scary. They don't look so bizarre, atypical, or mitotically active. But this is still a spindle cell squamous cell. Why do you have to rely so much on histologic findings? Because 30% of these will not stain for keratins. And, at that point, they might stain for SMA. So the staining pattern might be confused for a sarcoma. These are squamous cell carcinomas until proven otherwise. That's the most common thing that it could be. Common things being common, really sample, look for that in situ component, do your stains, try your best, do a whole panel, add as many keratins as you need. And really work hard to kind of prove that it is. But yes, it can be just keratin negative. But I think as long as you rule out other sarcomas and you rule out inflammatory myofibroblastic tumor, you're going to be pretty good with your diagnosis. This is just a little reference. I'm from Poland, and I didn't know what a spindle was when I was studying histology. So this is a spindle that the princess poked her finger on. So now I know. So they're like fusiform, kind of ovoid shape. That's good to know. But yeah, your differential diagnosis is if it looks bland, and the clinical history is not really mass forming, it's more like a constricting, it's probably laryngeal stenosis, which can be idiopathic from prior intubation or from some other prior trauma, almost like a scar process. Inflammatory myofibroblastic tumor, there's going to be a lot of inflammation and it's going to be quite cellular. And you're going to work it up with ALK and you're going to do, full workup. If it looks more atypical, your differential diagnosis includes post-radiation atypia, or even atypia that can be seen in polyps, but they're going to be keratin negative and they're going to be more like scattered cells, not so much like a proliferation of spindle cells. And you're going to see other post-radiation changes, or in a polyp, maybe you'll see myxoid stroma or more like hyalinized stroma. And then sarcomas, of course, like in your immunohistochemistry is going to be what helps make that diagnosis. But in the end, if it's high grade and spindle, then in larynx it's SCC until proven otherwise, even if no inciting component is ever identified. Inciting component is the biggest help. So what's the treatment? It's the same, and prognosis is felt to be a little bit worse, but low stage tumors do well. Basaloid. Again, predilection for males, typically not associated with HPV. Some thought it was more aggressive, now we are not so sure. What does it look like? So it's going to be very basaloid, and what you usually think about is the central colloidal necrosis, and maybe some peripheral palisading, and sometimes like a juxtaposal alignment, but I can't say that I've seen a juxtaposal very often. More often when I think about basaloid SCCs, I think about that central colloidal necrosis. So the center of the nest is dying, and there's maybe some peripheral palisade on the periphery. They are kind of playing against each other, so maybe it is a little bit jigsaw. And the cells are pretty blue. So yeah, not really association with HPV or EBV, basaloid SCC. Adenosquamous, the name kind of says what it's going to look like. It's considered one of the more aggressive variants of squamous cell carcinoma. What does it look like? So this is another section of the larynx. This is a glottis, thyroid cartilage. And we can see here that this is a squamous cell component right here. I know this is low power. We're going to zoom in. There's a squamous component right here. And then there's going to be an adeno component right here. And books will often say that what it starts out is like, oh, the squamous is going to be superficial. And then as the squamous continues to go deep, it's going to turn into adeno. Yes, I've seen it look like that, but I've also seen it like side by side like this, or mixed with each other. I don't think these are collision tumors. I think that this is just one big adenosquamous. And here you can see true keratin formation versus ductal mucus-containing cells and things like that. So both components together. On a small biopsy from the larynx, for example, you could notice that you have a squame and that you have some of these areas that look a little ductal. And you could make a comment saying, well, this ductal component could represent overgrowth of just pre-existing glands that are in the area. But the possibility that this could be adenosquamous cannot be entirely excluded. Final diagnosis is deferred to excisional specimen if available in the future. You could raise that possibility even on an incisional biopsy if you're starting to see little glandular component. And maybe sometimes think, should I rule out a mucoab, let's say if you're in the oral cavity. You could always send for fish. I've had all situations happen where I said suggestive of adenosquamous or cannot rule out adenosquamous on biopsy, ended up being just squamous with overgrowth of glands. I've had a case where I said suggestive of adenosquamous on biopsy, ended up being adenosquamous on the resection. And then I've had a case that really bothered me for mucoep because the cells were like a little bit more epidermoid, like mucoepidermoid carcinoma is just like bigger, pinker, almost intermediate looking cells. And we sent it for FISH and it was mucoep. So those are some thoughts to think about in adenoid carcinoma. Acantholytic. This is rare, but it definitely does occur. And it has a poor prognosis. And this can be confused for adenosquamous. These aren't true friends. These are cells falling apart in the middle of the nest. They are undergoing acantholysis, and they are falling apart and they are pulling apart like this. This one is a little bit more obvious. I think that things are falling apart. This is a little bit less obvious. This could be confused for an adenocarcinoma. It's going to stain like a squame, and P4E is going to be positive. High molecular weight keratins are going to be up. You know, I've seen mostly, I think, on the lip associated. Yes, like a derm person might come to you with a consult and say, "Hi, I've got this kind of on the border of the lip. This is a little acantholytic." Lymphoepithelial. So right now I'm talking about lymphoepithelial of the oral cavity or of the larynx. I'm not talking about lymphoepithelial like appearing carcinoma of the nasopharynx. We're going to talk about that later. So in the larynx, it's mostly Caucasians. In the nasopharynx, we mostly think about Asian countries or Africa. And they're only rarely EBV positive. Some of them can be HPV positive. But again, we don't really test for HPV or in the larynx unless there is a curiosity from the clinical team or if there is a connection to the pharynx. If the tumor is large enough, that it ever touches the pharynx, then HPV testing is considered a good idea. But if it has nothing to do with the pharynx, then we just don't test. So what does it look like? The inflammatory cells will break up the nests and the sheets of tumor into tiny clusters or single cells, making it difficult to recognize as an epithelial nature of that. It's lymphoepithelial. This is hard on frozen section. This could be confused for a lymphoma. This could be missed in a lymph node. So oftentimes doing some sort of keratins before the again is going to be helpful to see the full extent that this tumor may have. That's just about its appearance. Carcinoma caniculatum. This is an interesting tumor because it leads to potential pitfall. So most commonly it involves the mandible and involves the gingiva. The carcinoma burrows as if it was making tunnels like a rabbit into the underlying gingiva all the way to the bone, kind of trying to burrow down like this with these openings, with these crypts filled with neutrophilic exocytosis, and then it actually does destroy the bone. This doesn't really metastasize, but it is like locally destructive. But if you get a biopsy of this, just let's say just this one cystic dilated structure, this is so well differentiated that this has been misdiagnosed as a cyst, or this has been misdiagnosed as just like reactive squamous epithelium. This has been misdiagnosed on frozen sections, this has been diagnosed on margins. So you have to think about, does that epithelium belong in that particular location? How far deep are you? Is there any atypia? How big is this mass? This is a destructive process. You have to put all these pieces together if it doesn't feel obviously like a carcinoma to you on your sampling, right? So let's say you might say squamous proliferation or well-differentiated squamous, atypical squamous proliferation, you know, and talk to the surgeon about what does it look like clinically. It's destroying the bone because it can be so bland and it can be so cystic. Yeah, recurrence is uncommon, but it doesn't make sense. Verrucous carcinoma. Verrucous carcinoma is a little bit of an enigma. Like we know it exists. So like this would be like an example of a buccal mucosa verrucous carcinoma. This is an example of a laryngeal verrucous carcinoma. You know, shaggy, exophytic. But to get an excision of a perfect verrucous carcinoma, I have yet to have had one that is perfect. To make the diagnosis, you need to have adjacent normal epithelium on one side and adjacent normal epithelium on the other side. And it has to be pushing invasion. Just pushing invasion. Just keep pushing invasion, not infiltration, but just pushing. So if you get a biopsy from the middle of this, you're never going to be able to say that there was normal on one side and there was normal on another and then it went under. If it's tangential, it'll be hard. If it's fragmented, it will be hard. If the resection is not perfect and the section is not perfect, it'll be really hard to say that it was just this perfect pushing invasion. So it's tough on biopsy to call this, and it's not as common as I think it is. And also this can contain a conventional squamous cell carcinoma component at its deep aspect. And then once the conventional squamous cell carcinoma component is like, I think beyond 2 millimeters, then it acts like a conventional squamous cell carcinoma. So it has to be well oriented, well sampled, and well assessed, because the ones that are, I guess, true verrucous cell carcinomas do well, but the ones that have the conventional component act more like a squamous cell carcinoma, conventional squamous cell carcinoma. On incisional biopsy, you could say that this is innate verrucous squamous proliferation. Differential diagnosis includes verruca vulgaris or well-differentiated squamous cell carcinoma. Adjacent mucosa or underlying mucosa is not present for evaluation or cannot be assessed for pushing invasion due to fragmentation and lack of orientation. And the clinician kind of has to make the correlation. I would say that verruca vulgaris is extremely rare in the oral cavity. Verruca vulgaris is caused by HPV that likes skin. It's a skinotropic HPV, not a mucosotropic HPV. So I make the diagnosis of verruca vulgaris almost never. For me, it's an atypical verrucous proliferation with dysplasia, it's proliferative verrucous leukoplakia, or it's a verrucous carcinoma, or it's a well-differentiated squamous cell carcinoma with verrucous and papillary features 99% of the time. And verruca vulgaris 0.001% of the time. Okay, so like that's how little I favor it to be just a verruca. That's how much I favor that this is something verrucous in the oral cavity. Always worries me. Always worries me. Always raises my concern for dysplasia. You know, would have to be perfection for me to call it a verruca. Perfect orientation, perfect appearance, perfect situation, absolutely no pushing invasion. I feel it looks so bland. So locally destructive but without metastatic potential, but it can have this component of conventional squamous SCC. And if this conventional SCC is greater than 2 mm, then it's going to behave like a functional SCC. So taking a quiz about what we just talked about. So I'm going to go just down the line. We're going to start here. So first question, if I can see it. Squamous cell carcinoma with acantholysis, creating gland or duct-like appearance, rare in the oral cavity, may occur in the lip, has a poor prognosis. What's the name of it? Acantholytic. Okay. Next, okay. Both squamous and adenocarcinoma components. Aggressive. Okay. Kristen. Basaloid cells with cometonecrosis. Basaloid. Okay, so that's burrowing invasion.
Carcinoma cuniculata.
Perfect. Okay, next, with lots of lymphocytes.
Lymphocytic.
Lymphoepithelial carcinoma. Next one is exophytic with finger-like papillary projections, better prognosis. Raspberry. All the way in the back? No. Without epithelial architecture and composed of spindle cells. Spindle cell squamous cell carcinoma. Yep. And then the last one is this with Baruch's architecture, low grade Baruch's squamous cell carcinoma. So we're in all the different subtypes. So let's move on to the oropharynx. Oropharynx, the big talk in the oropharynx is always HPV, HPV. Like the entire picture of what squamous cell carcinoma can look like has changed in the last 30 years. We still always associate carcinomas with older men, drinkers and smokers. Now we associate them with younger men with HPV virus. The patients often present with a neck mass, and they say, I have myself shaving, I have a lymph node here or something. What is this, doctor? And then they go and they get treated with antibiotics for weeks and weeks, and it doesn't resolve, and it doesn't resolve. And then they finally get FNA, and it's non-keratinizing SCC. And then they get finally they get the direct laryngoscopy with biopsy, and sometimes they find a mass in the tonsils, and sometimes they do not. Because the primary can be so small. The primary can be tiny, tiny, tiny. So the patient's often more aware of this first than they are of the mass in their tonsil. Yes, you can still get your smoking and drinking SCCs in your oropharynx. They're usually going to be keratinizing. So what's the difference? So HPV is increasing in frequency, and the HPV independent are decreasing as people started smoking less, but now I don't know what's going to happen with me. I'm not sure how that's going to work 20 years from now. Younger patients versus older. The risk factors is an increasing number of sex partners, and then here's smoking and drinking. Like I said, small primary, but a large nodal met. And for the smoking and drinking, it's hard to know. Usually patient comes in with like an ulcer or a feeling like a globus sensation, or I can't swallow or something like that. Usually the primary is larger than the met, but sometimes they get present too. Site of origin, it likes to start in the crypts of the tonsils, while the smoking and drinking SCC, keratinizing SCC, starts at the surface of the epithelium. Precancerous lesion, very interesting. So we do know of dysplasia, and we do know of carcinoma in situ for our keratinizing SCCs. There is no dysplasia and there is no carcinoma in situ for HPV. And I'll show you an example. There's just isn't. We do not know about this. In theory, in practice, I've seen weird things. Morphology is usually non-keratinizing. This one is keratinizing. Grading, we don't grade. You know, here they say we grade, but in this institution, we don't grade any of our carcinomas. It doesn't seem to have any prognostic reason to grade. E16, positive, typically negative. Not completely negative, typically negative. And then survival, people usually do pretty well. We even have de-escalation studies that happen at this institution where they don't even get surgery, they just get chemo reds. So just going over our normal tonsil, this would be our palatine tonsil covered by squamous epithelium, and as we're going down, it's transitioning into that crypt epithelium. This epithelium is different than the one in the crypt. This epithelium is stratified squamous epithelium with the continuous basement membrane. This epithelium is reticulated, almost like a sieve, with the discontinuous basement membrane. This allows for antigen presentation, but this also allows for the HPV virus to kind of get in. So when you look at an inflamed, obviously, you know, we look at tonsils and we go fast through them. I'd say spend some time looking at the epithelium that lines the crypts. It is quite sieve-like, with lots of these inflammatory cells in between. And this is what I mean by discontinuous. HPV-mediated squamous cell carcinoma resembles that. It resembles that crypt epithelium. It's non-keratinizing. So the cytoplasm is often amphiphilic to basaloid, and usually not that eosinophilic dense cytoplasm. A little bit of maturation here and there is okay, but most of the time it's quite non-keratinizing. How does this happen? So the viral HPV virus, it integrates itself into the DNA, and then HPV E6 and E7 mRNA leads to inactivation of P50 E6 leads to inactivation of P53, E7 leads to inactivation of RP, and protein 16 is upregulated. Because protein 16 is upregulated, we can use P16 immunohistochemistry to look for that protein 16 upregulation. Fantastic, right? So sometimes the immunohistochemistry for P16 is enough. There may be some institutions that just do P16 and they're done. They don't even it's non-keratinizing, it's in the oropharynx, P16 signed out, call it HPV related. They don't do HPV DNA testing, they don't do RNA testing, they don't do molecular subtyping, nothing. It's good enough, it's been proven, it's a pretty good predictor in non-keratinizing oropharyngeal SCCs. At this institution, we do the whole workup. For many reasons, a lot of them are studies, and a lot of them are de-escalations. We still kind of divide HPV 16 subtype from 18 from the other ones, okay? But if it's the perfect storm of non-keratinizing oropharynx, P16 positive, you could be done. If something is not quite right, let's say it's keratinizing, then don't be done, and then keep working, okay? P16 immunostain, this is a normal tonsil. In your normal tonsil, you're gonna have some P16 pickup. Be aware of that your crypts are gonna pick up like this. Be aware that your germinal centers are gonna look a little P16 positive. What is a true P16 positive stain pattern? Is this okay? Is cytoplasmic okay? Is just nuclear okay? Is patchy okay? Or does it have to be 70% or more of cells with strong and diffuse nuclear and cytoplasmic staining? It has to be this corner up here for you to feel like, yeah, it's predictive of HPV. It has to be this. Anything less than this, we usually do it like this. 70% or more, yes, done. P16 is positive. 50 to 70% or nuclear only or cytoplasmic only, equivocal. Less than 50%, you could probably just call it negative and move on with your life. Rarely are you going to be at that 50% cutoff. It's going to usually be like 10%. 15% of cells are taken up, just call it negative. So in this situation, maybe you don't have to do the additional testing. In this situation or in this situation, let's do the gold standard. Let's do the HPV high risk RNA insider hybridization studies. These studies are going to detect the presence of any of these subtypes. Okay, these are your high risk subtypes. I think the list is now even longer. And this is as a reminder, these are some of your lower subtypes. But this HPV 67 that we talked about, the RNA, it tells you that it is being transcribed. We used to do DNA, that wasn't good enough. We used to do PCR, like that wasn't necessarily good enough. We had contaminants, we had call them like passenger like findings. This truly tells you that the virus is integrated and actually replicated. So so we do this. This is your perfect P16 result that you want to see, diffuse strong positive staining. And if it's not perfect, if it's equivocal, if your institution wants you to do ISH, if it's for a study, whatever, this is what HPV inside hybridization mRNA results are going to look like. They're going to look like these tiny little dots, not often this strong. You have to look on your high power, you have to look really closely to see that it's truly positive. Sometimes it'll jump out at you, it'll be like quick, but just FYI, this can be very speckled, very delicate, very dainty. Positivity, and it counts. It's true. This is telling you that the virus is there. What are some other issues with the P16 immunostain? P16, like I said, is predictive if you have the perfect storm of that it's non-keratinizing. let's say let's say you have a keratinizing SCC and it's P16 positive. Just double check with the ISH. The P16 protein can be upregulated from other things that went wrong in the cell cycle. So do the ISH. And then P16 may be false negative on cytology. We do run into this issue on tumor board fibroblast. The patients had an FNA. They called it non-keratinizing, but it's P16 negative. Can we believe it? The patient has a primary in the tonsil. Probably it was just a false negative. Something about the fixation process and sometimes was the P16 negative. So I think we started doing ISH on cytology. I don't know what's the validation process and where it stands and what the current working tree is like for using ISH, but ISH is going to be your gold standard. Or if your P16 is negative and maybe your HPV ISH is negative on your non-keratinizing SCC, then maybe do EBV just to rule out that it's some other viral non-keratinizing carcinoma. So do they all look the same? I said that they're all okay. So there's this great paper called Catch Me If You Can by Dr. Lewis. I love this paper. And this is based on the movie Leonardo DiCaprio, where he pretended to be a lot of different people, pretended to be a doctor, pretended to be a pilot, pretended to be all these other things. And this is teaching us that HPV virus can do a lot of things, and it can make the cancers look different every time you look at them. Yes, a lot of them are going to be just this plain non-keratinizing nests, but sometimes they're going to have a little bit of a different appearance. So first, just going back to the fact that I said that there is no carcinoma inside it. The reticulated epithelium is like a seed. If you see this much, this thick, and this is going to be dense P16 positivity, or it's going to be positive by ISH, this is already invasive. We're calling this invasive. You don't see it trickling into the adjacent stroma, doesn't matter. The basement membrane is discontinuous. This is invasive squamous cell carcinoma, okay? Only for HPV, only in the tonsil, you make the diagnosis. Other appearances. You can have like nests that are a little bit more basaloid. You can have the lymphoepithelial type. You can have the adenosquamous type. You can have papillary type, okay? All very streamy, very basaloid, HPV positive. If you get this in the pharynx, it's non-keratinizing on a frozen, and it's papillary and it's complex, you can call it papillary squamous cell carcinoma or positive for carcinoma, even if you don't see an lesion. Tricky one, you can have ciliated HPV-mediated squamous cell carcinoma. This one is quite new, discovered a couple years ago. Very tricky. People used to think that if something is ciliated, it's not malignant. Not anymore. They can be cystic. So a patient comes in with a big cystic mass in the neck, and people are like, it's a branchial cleft cyst. And they do P16 and it's positive. Branchial cleft cysts can be P16 positive. So you need to do ISH on your cystic lesions. You need to do ISH. Your meds, your SCC meds can be cystic, but usually the epithelium is going to look atypical. But if it's very attenuated, if it's very, very thin, don't just call it a branchial cleft cyst. Do the ISH just in case, right? Because they're like, oh, I don't see any primary on laryngoscopy, and they just got this neck mass, and that's the only mass that they have. Just do the ISH. They can have these bizarre cells. I think there's someone working on trying to figure out if they have a significance or not. But you can have these anaplastic looking cells in there. They don't mean anything thus far. But I find them to be kind of helpful. Like when I see them, I'm like, oh yeah, it's my HPV-related SCC. And then this is the biggest pitfall of all. If it looks like small cell or large cell, then it does not matter that it's HPV positive. This patient has a poor prognosis. This is easy to miss because our HPV SCCs are very blue, very mitotically active. So if you are at all, when you look at a biopsy, and you're at all like, this looks a little bit like small cell, this looks a little bit like large cell, I don't know. Just do a P40. Your HPV carcinoma is supposed to be diffusely P40 positive. Just do a P40, get a couple unstained, do your P16, P40, and I do them as a pair. So a lot of my reports are like positive for P16 and P40. Just because a little corner of my head was like, I don't want to miss a small cell, or I don't want to miss a large cell. So oftentimes I'll just do both markers. Unless it's like a super nicely nested tumor, then I don't do the P40, but I do P40 a lot. And then your small cell would have a A1, A3 perinuclear dot, and then it would be positive for neuroendocrine markers. Neuroendocrine markers. Chromogranin and synaptophysin we have in this institution, right? Other institutions are using this marker called INSM1. I think we still have a lot to find out about INSM1 because from practice, from having used it, it's going to get picked up in like more things than you thought. So just be aware when you go to a different institution and they're using INSM1 as their neuroendocrine marker more so than their chromogranin synapto. Really talk to the people that work there and ask them, what has your experience been like when you have ordered this? Have you had to write a note where like maybe there's a possibility of neuroendocrine differentiation? Like, just know your markers, the newer markers on the market that are sometimes out there. We get very excited about them as being like the next best thing. But then you start using them and you realize that sometimes they get you into like situations where they're kind of hard to describe, like, what are your findings? What does this mean? Nasopharynx. Nasopharyngeal carcinoma, the most common site is the fossa of Rosenmuller. It might be a fourth question. Usually we see keratinizing, non-keratinizing, or basaloid SCCs in the nasopharynx. There's also like this low-grade papillary one, but I'm not going to talk about it today. I just want to talk about squamous cell carcinomas. And so again, the keratinizing, we're thinking smoking and drinking. The basaloid, we're more likely thinking smoking and drinking. The non-keratinizing one, we're thinking virus again. We're thinking EBV virus in the nasopharynx. Sometimes the basaloid can be related. So the EBV component is a little bit enigmatic. There's a lot of people who might have the EBV virus, and they don't all develop nasopharyngeal carcinomas. There is some connection to like the diet with fermented foods and fish, and maybe like environmental, and so then like heredity and predisposition and things like that. We haven't quite figured out what is like the combination that causes people to develop this carcinoma. And what's nice is that EBV serology is positive in most patients. So oftentimes the clinical team will do the imaging, they'll do the serology, and they'll kind of like wait for you to like make the confirmation. And they will also monitor the patient with the EBV serology throughout their life. By the way, now they're also doing like HPV serology too. Yes. So in Asia, it's common in adults. In Africa, it's common in children. And in Europe and in the US, it's kind of uncommon. This would be the keratinizing types, similar to keratinizing SCCs in other areas. You're going to have that dense eosinophilic cytoplasm, right? Very dense cytoplasm in some keratin-like formation versus non-keratinizing. Non-keratinizing is going to involve epithelial. Like, do not miss this when someone sends, let's say, adenoids, right? So you'll be thinking, germinal center, blah, blah. It's kind of, sometimes it can be hard to see if they're worried about a mass, if you're having a little bit of a hard time seeing, is this like inflammatory cells? What is this? Is this a lymphoma? Do your whole IHC workup and the EBV inside of hybridization. Because this could be obviously a lymphoma as well. Sometimes they are a little bit more syncytial, the cells, or like cohesive. And this is much easier to diagnose both on biopsy, like quickly. If more confident this is carcinoma. Maybe you don't do like the confirmatory, like keratin states, you just do the EBV in this case. And they're non-keratinizing. And then this would be like the EBV inside of organization is slightly different. Colors and backgrounds of inside of organization. Like this is what it look like. And the stage is of the presentation is the most important prognostic factor. So for the last 10 minutes, I just wanted to add something that I think maybe isn't talked about enough, but I think it's on the rise or it's going to be talked about more. And it's the nose. So we went through, like, our first lecture was just like mostly our oral cavity, keratinizing squamous cell carcinoma, staging, depth of invasion, lymph nodes, external extension, things like that. Then we went through all the different variants that tend to occur in the oral cavity and in the larynx. Then we went and we talked about the pharynx and how that's mostly HPV related. Then we talked about the nasopharynx, and that's mostly EBV related. But now we're talking about the nasal cavity. And in the nasal cavity, we used to think about like, maybe there's some like low risk HPV with some of our like papillomas, like, right, sinonasal papillomas or things like that. But there's actually a carcinoma in the nose that's called HPV-related multiphenotypic sinonasal carcinoma. And I think from experience, we started seeing these more. Like, I don't know if they were underdiagnosed before or if they were misdiagnosed before, because they look like solid, very bland type neoplasms. They have both like squamous differentiation, and they have myoepithelial and ductal components. So you're gonna see dysplasia in the overlying epithelium, and then you're gonna have an infiltrating tumor that's gonna have myoepithelial and ductal components. So the myoepithelial components are gonna be highlighted by 40 SCC3 SMA. The ductal component is gonna be highlighted by CKIT, and then both components are gonna be highlighted by S100 and SOX10. This is a good paper that's expanded its morphologic features. It used to be called adenoid cystic carcinoma-like. I'll show you because it looks like this. You would get this biopsy, you'd be like adenoid cystic, done. No, unfortunately, no. This is HPV-related multiphenotypic sinonasal carcinoma. It can look like this, look like this, like this, like this. You have the myoepithelial component, you have a ductal component, and then you have this in situ component in the overlying epithelium. And if you do HPV-ish, all of this is going to pick up. The overlying epithelium is going to be positive for the ish, and the infiltrating tumor is going to be positive for HPV-ish. Your ish has to include HPV-33. This is most commonly HPV-33. So if your high-risk ish only has 16 and 18, and some institutions, some hospitals only have those two, you're not going to pick this up. So you need to have the like spectrum inside of the organization to really prove this. But that in situ component overlying the tumor should be like that little clue that this is squamous kind of HPV process. And here we have ductal component, myoepithelial component. This looks very much like any of our salivary gland tumors, like an adenocarcinoma. It can look epithelial, myoepithelial. It can have those bizarre giant cells that we saw in the other HPV-related tumors. It can have a squamous component. It can have cartilaginous, some dedifferentiation. You know, it's odd. It's a little bit bizarre. And I would say that once you've kind of like worked up your tumor for like everything else and you ruled out the classics, then think about, oh, am I missing this one? Oh, I should throw HPV on this sinonasal tumor. And maybe it's this, because we're still kind of discovering its full spectrum of histologic appearances. So how does it compare to the oral pharynx? So it seems to be that the age range is a little bit wider. It seems like it's maybe a little bit more women. We are not sure. We think maybe it starts in ducts, and that's why it has this appearance, maybe something close to the surface of the epithelium. Hard to know. We don't understand it as well as the HPV and how it enters the tonsil or crypts. It looks more so salivary-like. The most common HPV type is 33, and it usually doesn't metastasize. So remember the ones in the oropharynx, the patient comes in with the big mass. The ones here, not so much. And the outcome, but the outcome is favorable for both groups, even though it looks big and mitotically active and things like that. It seems to be pretty favorable outcome. And P16 is not the most reliable surrogate marker anywhere outside of neuropharynx. So I'll just say, just P16, it has to be the perfect storm to use it as the oropharynx, not third base. P16 can be done. In other areas of the body, pretty much need to do ish, and it has to include HB33. But I think that's it. I think that's all I wanted to talk about. I mean, there's a lot more carcinomas in the nasal cavity and base of skull, but I feel like that requires like a full lecture of its own to talk about everything that happens there. But I hope that at least you guys are thinking about the virus and virus-related cancers in the head and neck and smoking and drinking related cancers in the head and neck. And then this will help you know, to think about when is P16 reliable by itself and when do you need to do additional testing. So any questions about it? First week today, I think I'll have another lecture